Hello guys, today's topic is short stature. Introduction. It is defined as height below the third standard or more than 2 standard deviation below the median height for age and gender according to the population standard. Standard deviation more than -3 is pathological and the standard deviation between -2 and -3 are physiological short stature. Etiology. Etiology, you can divide it into physiological causes and pathological causes. In physiological, it comes in familial and constitutional short stature, and in pathological, we can divide mainly it is into undernutrition, chronic systemic illness, and endocrine causes. Now we can discuss the which are other chronic systemic illness and endocrine causes. The cerebral palsy, congenital heart disease, cystic fibrosis, asthma, malabsorption, AIDS and other chronic infections comes under the chronic systemic illness. Endocrinal causes like growth hormone deficiency, hypothyroidism, Cushing syndrome, pseudoparahypothyroidism, precocious puberty, small for gestational age, and genetic syndromes like Down syndrome, Turner syndrome are the etiologies. Assessment. We can assessment of the short stature is based upon certain parameters. They are the accurate height measurement, which is done in children below 1 year, is measured using the infantometer, and children older height should be measured using stadiometer. The assessment of height velocity. It's the rate of increase in height over a period of time expressed as centimeter per year. The average height velocity is 25 centimeter in first year. In prepubertal children, it is 4 to 6 centimeter per year. In puberty, it is 10 to 12 centimeter per year. Comparison with the population norms. Height should be plotted on appropriate growth chart and expressed in centile or standard score, or comparison with the child's own genetic potential. It is calculated by mid-parental height. For boys, the mid-parental height is mother plus father's height in centimeter divided by 2 plus 6.5 centimeter. And for girls, mother's and father's height in centimeter divided by 2 plus minus 6.5 centimeter. The value is plotted in growth chart in 18 to 20 years of age. Assessment of body proportion. Short stature can be proportionate or disproportionate. The proportionality is assessed mainly by the upper segment and lower segment ratio and the comparison of arm span with height. The normal upper segment lower segment ratio is 1.7 at birth and 1 at age of 10 years and 0.9 in case of adults. There is increase in upper segment is to lower segment ratio in case of rickets, untreated congenital hypothyroidism. There is decrease in upper segment and lower segment ratio in case of vertebral anomalies. Then for the sexual maturity ratio, the SMR staging should be assessed in older children. Delay puberty and precocious puberty may be lead to a short stature. The investigations done in case of short stature are complete hemogram, bone age, urine analysis, microscopy, osmolarity and pH, and stool examination, blood urea, calcium, phosphate and alkaline phosphatase, pH of the blood, bicarbonate and creatinine levels. Serum thyroxine and TSH levels are to be investigated. Karyotype in girls are done to rule out Turner syndrome. MRI brain, provocative growth hormone testing and celiac serology. Management. The main management depends upon general principles of management of a child who presents with short stature include counseling of the patient and dietary advice. Intake of balanced diet containing sufficient amount of micro and micronutrients is recommended. For physiological causes, annual monitoring of height and assurance is sufficient. Whatever may be in the form of therapy, the monitoring with a regular and accurate recording of height is mandatory for satisfying outcomes. For skeletal dysplasia, limb lengthening procedure is offered at a few orthopedic centers. For hypothyroidism, levothyroxine is given. For growth hormone deficiency, subcutaneous injection of the growth hormone is also recommended. Thank you.